Regenold. Now we're being recorded. Um, Please note, so Dr. Regenold is speaking um, on electroconvulsive therapy, effective, rapidly acting, and versatile. So this is ECT is the oldest rapidly acting treatment that's approved for both depression and bipolar disorder. Um, And so he's going to talk about the history, refinements, current practice, research into um, improving improving the balance. I think maybe comparing it with other treatments. Dr. Regenold, his medical training was at McGill University in Montreal. He had an internship at Johns Hopkins Bayview, residency in psychiatry and old age psychiatry at Johns Hopkins in Baltimore, and Maudsley Hospital in London. He is senior research physician in the experimental therapeutics and pathophysiology branch of the National Institute of Mental Health. He collaborates with research team on electroconvulsive therapy and transcranial magnetic stimulation therapies for treatment-resistant depression, and he's had a number of other positions. I guess that's probably enough for me to say. We're very pleased to have this talk. Dr. Regenold works with, I believe, our medical advisor, Dr. Zarate at NIMH. Dr. Regenold, Bill, go ahead.
Yeah. Okay. Thanks, Alvin. Thanks for the intro, and thanks for having me here to talk. Sorry for the glitch. I will get started. So, yeah, this is where I work. This is the NIH Clinical Center, and it is the world's largest hospital dedicated exclusively to research out there on Rockville Pike in Bethesda.
Yeah.
And this is an outline of the talk.
Okay,
So,
may I say one other thing?
yes, go ahead.
We'll have questions at the end, but if people have questions, they can place them in the chat during the talk.
Okay.
All
Yeah,
right.
that's fine. And if you want to, you can call them to my attention.
Okay.
Okay. So what is electroconvulsive therapy? Well, it's an FDA-approved treatment that involves the serial induction of generalized seizures under brief general anesthesia and neuromuscular blockade, also known as paralysis, using alternating current applied through scalp electrodes. So alternating current is the kind of current that comes directly out of the regular outlets that we have. It's performed by an ECT credentialed psychiatrist assisted by an anesthesiologist and nursing staff. Typically, it's given as a course of 6 to 12 treatments, generally in the United States thrice weekly. And the most common diagnostic indications are severe treatment-resistant major depression, we'll call it TRD, and that's either unipolar or bipolar. Other FDA-approved indications are severe bipolar manic or mixed states, catatonia, treatment-resistant schizophrenia, or schizoaffective disorder. It's a relatively safe procedure that can be given to inpatients or outpatients. It is not that commonly used. Only 1.5% of all psychiatric inpatients with diagnoses of major depressive disorder, bipolar disorder, and schizoaffective disorder actually receive ECT. One interesting thing is that it's much more commonly received by older people. So if we look at the relationship with age, the group 18 to 34, their rate of ECT use is about 5% in this study, whereas it's 4 times higher in the older group. There are probably a lot of reasons for this. As we get older, we have more medical problems and interactions with medications. Also, it's more common in older people to have medical complications of depression, for instance, sometimes due to lack of eating and drinking that require rapid improvement. And so ECT is sometimes very helpful in that context. So you may ask, how did we get here? Who had the idea of using seizures to treat mental illness? It doesn't seem obvious. We can trace it back at least to the 16th century when Paracelsus, a Swiss physician and alchemist, gave in the translation gave camphor by mouth to produce convulsions and quote unquote cure lunacy. Um, you may know that Paracelsus's actual name was quite long, and that's why he probably was called Paracelsus. Camphor goes way back. It originates in East Asia, and was brought to Europe through trade, and that's what was used to induce seizures way back when. But giving something orally is problematic because in terms of its onset, it's variable. And so when somebody has a seizure, you want to be prepared and you want to make sure that they're safe. So giving something orally wasn't great. And so a Hungarian psychiatrist, Dr. von Meduna, decided he would try injecting it in oil to induce convulsions in somebody who had catatonic schizophrenia. He first used it in guinea pigs. So he wanted to test it out, make sure that it was tolerated at least, and then tried that. And eventually, camphor was replaced by drugs that were more water soluble and therefore easier to inject into the bloodstream. And you see an example of one right here, pentylene tetrazole. So that was used for a while to induce seizures by giving a medication. The problem with this, though, is that the drug prior to the seizure induced an aura. And you may know, and with seizures, sometimes people who have epilepsy, they'll have an aura before their seizure. And often the aura is not pleasant. It can be sometimes a smell, but often it involves extreme fear. And so that's what happened with this. People, before they would have the seizure, would have the sense of extreme dread. And so, because we know that you need to have a series of these treatments, a series of seizures to get better, people weren't very keen on repeating the experience. So, the thought in the psychiatry world at that time was, how do we induce a seizure without this kind of side effect? And that's where a couple of psychiatrists in Rome came in. So, Ugo Cerletti and Lucio Bini, they first experimented in animals, but eventually in 1938 induced the first electrically induced seizure in a 39-year-old man from Milan who was delusional, hallucinated, and wandering the Rome train station. We don't know exactly what his diagnosis was. But this was the device. It doesn't look very pleasant at all. You can see these are actually sheepskin soaked in sort of salt water because that conducts electricity. And these would be applied to both temples. And this box is the device that would then provide the electricity. And after 11 treatments, the patient was reported to recover and to go back to his relatively normal life, at least briefly. And then the treatment came to the U.S. and very soon thereafter, in 1940, two Italian doctors used it in New York City with a device they got from Rome. So that's how it came over to the United States. And then everybody realized that this treatment was helpful, but it had a lot of side effects. And one of the problems was that, especially in those days when people used much higher doses of electricity, it caused very strong convulsions. And with those strong convulsions, there was the risk that some people, especially older people, perhaps with more brittle bones, could actually break bones. And many nursing staff had to often hold people down when they had these seizures. So this was definitely a problem, and people wanted to solve it so that the treatment could be used in a more benign way. So interestingly enough, the first use of a paralytic, a curare-based paralytic, that derives from the frogs of the Amazon, was used in psychiatry, not in other areas of medicine, but in psychiatry. So a rather enterprising psychiatrist from Nebraska, A.E. Bennett, had the idea of using a curare-based paralytic, and giving that before the electricity so that the muscles would be paralyzed and relaxed, and the person wouldn't have such vigorous convulsions, putting them at risk for bone fractures. Eventually, because the curare-based paralytics, which are still used today in synthetic form, so for long procedures like operations, many times people are given medicines that are derived from curare, but they are long-acting. And so because ECT is such a short procedure, in the 1950s, when succinylcholine came around, that was introduced as the paralytic with ECT because it's very short-acting. So that was a major step forward in terms of the safety of ECT. And then, of course, it is not pleasant to be awake and paralyzed. So the idea is to have somebody paralyzed so their muscles don't contract so vigorously and they're not at risk for bone fractures. But then if they experience that, it's frightening. And so the idea at that point was, how do we deal with that? We deal with that by giving barbiturate general anesthesia that works very quickly and very briefly to eliminate that fright of paralysis. And the first that was used was sodium pentothal. And these days we use a different barbiturate called methohexital. And that's dosed on the basis of how large the person is on a milligram per kilogram basis. So all these things were done to make ECT a more safe and tolerable procedure. Then in the 70s and 80s, the emphasis, and since then, the emphasis has been more on how we can decrease the cognitive problems associated with ECT, because ECT typically will induce some degree of cognitive problems in most people, most notably memory impairment. So then people started experimenting with the treatment that way. And what they found was that if you change the waveform, so electricity is administered in certain waveforms. The initial was this sine wave like this. People started experimenting with what we call bidirectional brief pulses for the electricity. And what they found was that if you did that, you could use less electrical energy to induce a seizure with these sort of waves. And if you use less electrical energy, it caused typically less memory problems. The other thing that people have been doing since I'd say the 80s at least, is to try different electrode placements. So the one you saw with the original patient with those bitemporal electrodes is this bitemporal, where you put an electrode in what we'd call the temporal socket behind the eye on both sides of the head on the scalp. But then more recently, people tried different electrode placements. And so here you see right unilateral, where you just put electrodes on the right side of the head, so one in the right temporal socket and then one toward the top of the head on the right side, or bifrontal, where you put two electrodes in the very front of the head. And what we found with those is that they tended to cause less problems with memory because we avoid sending the current through the temporal lobes, which are very important for encoding memories. So that's sort of the history of ECT with its refinements. I'm going to talk about the procedure now. So this is what it might look like in a room where ECT is given. It can be given in a procedure suite or an operating room, generally some part of a medical facility. It doesn't have to be a sterile area, but generally what we need is an ECT cart right here and also an anesthesia cart. Often it will happen in some general hospitals in what we call the PACU, or post-anesthesia care unit, where often patients recover. So there's an anesthesia cart, ECT cart. And as I mentioned before, the treatments are usually given in the morning, 3 days a week, Monday, Wednesday, Friday. What happens is you need an IV catheter placed. So you get an IV line. That's to give the medications, the succinylcholine and methotrexate. Patients can't eat or drink anything after midnight because we want them to have an empty stomach so there's very little risk that they're going to have any problems with bringing anything up that could cause problems with choking. The procedure usually only lasts about 15 minutes, and we try to follow any benefit and any adverse cognitive at least weekly with outcome scales. So we'll use a depression rating scale and also some scale to assess cognition throughout the course to see how patients are doing. These are the two ECT devices that are kind of on the market. Um, I often say they're sort of this, they look kind of like stereo receivers, especially the one on the right. But when I use that analogy, or these days, a lot of the younger people look at me like they don't know what I'm talking about. So, but I don't know the average age of this group, but to me, they look like stereo receivers. And to kind of, they're pretty simple machines. But the idea is they take the current that comes out of the outlet and they will then modify it so that they'll bring down the amount of energy coming out of the outlet and also allow through the device for us to kind of manipulate the different components of the electrical energy so we can try to individualize it to the patient. To give you an overall idea, the current amplitude that comes out of these devices is at a maximum of 0.9 amperes. And if you get current out of your home outlet that is unchanged, you're talking about 15 to 20 amperes. So with ECT, it's much lower. To give you an idea of the energy, so you all know what automated external defibrillators are. Those AEDs, which we use to shock the heart into a more healthy rhythm, they usually apply in the area of 360 joules of electricity. The maximum allowed in a machine for ECT in the United States is 100 joules. So less than a third of that people use to heart. The other thing to keep in mind is in terms of the energy that's administered both with the AED and also with an ECT machine is much of that energy does not actually get to the organ like the heart or the brain. A lot of it's diffused through tissues before it gets there. This is a picture from a book of somebody getting ECT. Usually people are wearing a hospital gown or regular clothing. They're not just in their underwear. But it gives you a picture for how people are monitored. So people are monitored very carefully. They have an electrocardiogram with leads. They have the intravenous line. They have a pulse oximeter, so we can know what their oxygen is all the time. These are These are the stimulating electrodes. It looks like they're on bifrontal here, bifrontal electrode position. Then we have electroencephalogram leads, so we get a printout here. If somebody's having a seizure, we can tell from this printout. And there's typically a blood pressure cuff here. There's also a blood pressure cuff on the leg. So the idea is with the succinylcholine, the paralytic, much of the convulsions that you normally see are gone. There's very little movement in the body, but there is some. And what we try to do is inflate this cuff here in the leg before we give the succinylcholine. That prevents that paralyzing drug from getting into the foot. And so we can watch the person's foot to see if they're having a seizure by looking at the convulsive movements of the foot. We also get this printout of the EEG. And this sort of sawtooth look here, that's a typical look of a seizure. So I kind of went through what happens with the procedure, but basically all the sensors and stimulation electrodes are applied. Vital signs are monitored. The person is given the anesthetic. We inflate that cuff I told you about so that the paralytic medication doesn't get into the foot. Once the person's unconscious, the paralytic is given. then the anesthesiology doctors will, or nurse will use what we call mask bag ventilation, because the paralytic also paralyzes the breathing muscles. And so the anesthesiologist then breathes for you with 100% oxygen. And once we know the person's fully paralyzed, we give the stimulus. And the initial stimulus is dosed based on age, usually a higher dose the older you are. But we try to dose it according to everybody's seizure threshold, which varies quite a bit across people. So we will stimulate and see if we induce a seizure. If we don't, we'll increase the energy up a little bit and re-stimulate, and we'll observe for the convulsive movements in the foot and also look at the EEG to see if there's a seizure. And if there is one, it usually is pretty brief, usually anywhere from like 30 seconds to 90 seconds, more on the end of the 30 seconds. And the anesthesiologist, meanwhile, is continuing to give mask bag ventilation to the patient until they can breathe independently. So after that, there's recovery and then discharge. People are transferred to recovery when they're breathing independently and their vital signs are stable. Recovery is usually 30 to 60 minutes, really depending on the amount of confusion after the treatment. We check people's orientation after the procedure to assess the extent of confusion. So we'll ask them questions: what's their name? What day of the week is it? Things like that to assess them. If the person's an inpatient, we'll discharge them to the inpatient unit when they're awake, alert, following commands, and their vital signs are stable. If they're an outpatient, they can be discharged home with a responsible escort, but they can't take themselves home. And people are advised not to make important decisions, work, drive, work at heights, operate potentially dangerous machinery during or within 1 to 2 weeks after the ECT course because of its effects on cognition. I do have a video of ECT, but you know what? This is a very good video, but I'm not sure that it's enabled. I'm not sure that it's going to come on. Honestly, I think I probably needed to have done something to make this happen. Anyway, if you get a chance, take a look at this video. It's pretty good. This woman is getting outpatient ECT in Canada, and I've got the YouTube link here. The video is called ECT Therapy for Severe Depression. It's a 3-minute video. I'm sorry I can't show it now. It looks like the content wasn't enabled, probably something I needed to have done before I shared my screen. But that's okay. I think you can certainly take a look at it later. Like I say, it's 3 minutes. It's done by Covenant Health Canada. So take a look at it. It's pretty good. Now, ECT efficacy. What's interesting about ECT is that it is uniquely versatile. It's really the most effective acute treatment in psychiatry. And what's unique about it is that it has excellent efficacy across several diagnoses and syndromes. So major depression, it is most commonly used for. And that could be either bipolar depression or unipolar depression. Mania, it is also used for. It's very effective in mania. It's just that mania is not nearly as common as depression. And catatonia, also not as common as depression. It is very effective in catatonia. I'm assuming everybody knows what mania is. Maybe everybody doesn't know what catatonia is. So I'll just say a couple of things. Catatonia can come on an association with a medical illness, like say lupus, but it can also come on with a psychiatric illness. More commonly, actually, a mood disorder. I think people are used to hearing about catatonic schizophrenia. It does come on with schizophrenia, but actually, much more commonly, it comes on with major depression, particularly bipolar disorder and schizoaffective disorder. It's still pretty rare, but when you do see it, it's more often in a mood disorder. And it involves people most of the time moving very little, being mute, not eating and drinking. This person here that is pictured is doing what we call posturing. She's holding her arms in a certain position, and she will hold them there until somebody moves them. You don't see that often with catatonia, but when you see it, it's pretty impressive. And catatonia is a very dangerous state because people stop eating and drinking, and they can, for instance, even get bed sores because they're not moving at all. Um, so if we look at the efficacy in these psychiatric disorders, it's pretty high. So in major depressive disorder, unipolar, response and remission rates are 74% and 52% respectively. Um, and when we say response, we usually mean that somebody has a 50% drop in their depression scale score, which means a significant change in their clinical position, but their condition, but they still have some degree of depression. And with remission, we mean the depression symptoms are gone. So for about half of the people that get ECT, depression symptoms go away, at least temporarily. Bipolar disorder, the rates are similarly high, so remission rates of 65% in bipolar depression and very high in mania, 88%. Catatonia also very high, 80% remission rate. The other thing about ECT is it also helps people from coming back to the hospital. So many times when people are treated for depression with medications, as you know, all too often medication trial is unsuccessful. But when you have ECT, the treatment is much more definitive and is usually much more successful. So uh, therefore, the chance that somebody will be readmitted to the hospital in 30 days is about half that as if they did not have ECT. And this is in a study that looked at people with major depressive disorder, bipolar disorder, and schizoaffective disorder who were hospitalized and then either had ECT or didn't. And then people looked back at their readmission rate. There are some predictors of response to ECT. Whether you have unipolar or bipolar depression, it doesn't matter. ECT works for both. So that seems to be more or less neutral. Psychomotor retardation, and by that we mean somebody's thinking very slowly and moving very slowly. That tends to predict a good outcome, a good response to ECT. Catatonic symptoms predict a good outcome for ECT. Personality disorder, so comorbid personality disorder, where somebody has major depressive disorder and personality disorder, typically is not a good predictor of response, only because the personality disorder often can complicate things, and it's sort of a non-biological feature which won't respond to ECT. Psychosis predicts a good response. Older age does. High suicidal intent. Longer duration of episode, really for any treatment, does not predict a good response. It predicts a poor response. And then in terms of gender, it seems to be neutral. So what's interesting about ECT and sort of counterintuitive is that the sickest people, so people with psychosis, with catatonia, who have psychomotor retardation, they're moving slowly, thinking slowly, suicidal ideas, the sickest people actually are most likely to respond the best to ECT. We don't know why that is, but it's definitely the case. I'm going to give you some case histories here to sort of liven it up a little. This is a 70, these are all from the University of Maryland, where I worked for 24 years, basically the head of older adult psychiatry. And I attended very often on an older adult inpatient unit. So this was a 75-year-old married man who was brought by his family to the ER after 1 year of severe medication-resistant major depression with psychotic features and a 20-pound weight loss. His depression developed following a move from Florida back to Maryland to live near his family. He was tortured by his delusional belief that he had made a terrible financial decision that would ruin his family. His past medical history was notable for a stroke 9 years ago with right-sided weakness, which had resolved. This is a picture of his brain CAT scan, and I'll just point out that the areas of his brain where he had the stroke, so these darker areas are areas where he lost some brain tissue from the stroke on the left side of his brain. He didn't have any motor symptoms from this anymore, but we think it probably set him up for depression because he had no psychiatric symptoms or treatment prior to this episode of depression. He wasn't somebody who had lifelong depression. It came to him in old age, which is usually suggests that there's some sort of feature that could have triggered it. In his case, probably stroke. Um, so he was treated. He was admitted to our older adult psychiatric unit. He was so dehydrated that we gave him intravenous fluids. And with his wife's encouragement, he consented to ECT. And his depression and psychosis remitted completely with a 9-treatment course of bifrontal ECT. And he was discharged on antidepressant medication. He had another 2 courses of ECT over the next 5 years for lesser depressive relapses. So he did relapse, but he was brought back to the hospital before he got really sick. So we were able to help him get out of those depressions before, he needed intravenous fluids, for instance. And overall, he enjoyed the rest of his retirement, particularly with his family. If there are questions, maybe just bring them to my attention, Alvin. I'm just saying this because I'm not sure if there are. Another case history. This is a 72-year-old married retired university professor of veterinary medicine. He was brought to the ER by his wife for social withdrawal, minimum food, PO means per Oz, or, food and water intake, 30-pound weight loss, and mutism. He was treated by his wife with vitamins and herbal supplements. She loved him dearly, and she was very committed to vitamin and herbal treatments, but unfortunately it was not helping. And he'd had a significant past psychiatric history, having had sporadic episodes of mood disorder with psychotic features, but he hadn't had any recently. He was admitted to the unit, diagnosed with major depressive disorder with catatonia, and it tended to change over the course of the day. It was most prominent in the morning, where he was absolutely mute and still. So he was given IV fluids, and often the initial treatment for catatonia is benzodiazepines. He was given lorazepam up to a very high dose. He had some mild improvement. He was able to get out of bed when we give him the lorazepam in the morning, but he had no spontaneous speech. He'd just give us one-word replies. He ate minimally with encouragement. We discussed ECT with his wife and him, and he really wasn't capable of consenting. And we told his wife that this was in Maryland, we needed to get temporary guardianship if he was going to have ECT, so his wife could consent for him. But she was afraid of it, and she chose not to pursue it. So he was discharged after 2 months to home, and he was followed up in our clinic. But after several weeks, he relapsed into worsened catatonia. He was readmitted, again treated with IV fluids and lorazepam. And we discussed it again with his wife, and she did agree this time, because he was to the point where he needed a feeding tube. And we basically said it's either ECT or a feeding tube. And so she agreed, but she only agreed on the condition that we would let her be in the treatment room. And anesthesia wasn't crazy about that. They usually don't like family members in the treatment room, but I kind of convinced them, because I really thought I didn't want to see this guy get a feeding tube. So we let her in the treatment room, and she watched the first few treatments, and then after that, she was satisfied, and she sort of sat outside and waited till the treatment was over. And so that worked quite well for him. He wound up having bifrontal ECT, 12 treatments, and he did well. Another case history. This is a 67-year-old unmarried man without housing, referred by the medicine service to our unit after he was treated for hypothermia and malnutrition with a 20-pound weight loss. He'd been found in a culvert pipe in a Baltimore park. He said he'd crawled there to die. He had unclear past psychiatric history. It seemed like he had been admitted to a state hospital more than 10 years ago. And he was diagnosed with major depressive disorder with prominent psychomotor retardation and suicidal ideation. He was not catatonic, but he was very, very slowed down. He was treated with an antidepressant, and we increased the dose over several weeks. He had some minimal improvement. We discussed ECT after a couple of weeks as a quicker and more effective treatment. But in his words, he was afraid ECT would turn me into a human French fry. So he refused. But over the next 3 months, we gradually tried to educate and persuade him And he eventually agreed to talk with other inpatients who were getting ECT, and then he reluctantly consented. He had 9 bifrontal ECT treatments and his depression remitted. He was able to laugh and joke, and he had a normal appetite. It was really wonderful to see. And then when we asked him whether ECT turned him into a human French fry, he just smiled at us. So, so another thing was he was well enough to reconnect with a niece, who then welcomed him to stay in her home. So that was very important because he really had no other place to live. And then finally, this is another person with major depressive disorder with catatonia, 52-year-old unmarried woman. She was admitted for low mood, social withdrawal, mutism, poor, poor food and water intake. She had a psychiatric history where she'd attended special schools, never employed, lived with her mom all her life. She'd had these episodes kind of throughout her adulthood, but hadn't really gotten consistent psychiatric care for them. So we diagnosed her with major depressive disorder with catatonia. Um, she was admitted to the unit and, as usual, given an antidepressant, lorazepam. Um, and with eventual remission of so this time the lorazepam worked, and over 8 weeks she got better and was well enough to go home. Um, we'd had a family meeting at week 3. It was attended by 10 family members, and we'd offered ECT at the time, but they decided against it. But as I said, it took a long time, but she got better. So, so then she was followed up in our clinic, and she was on an antidepressant and lorazepam. And every time she'd visit, she'd have at least 4 to 6 family members with her. So we got to know her family pretty well through visits and phone calls. And the thing about being on lorazepam, it's a controlled substance, and so you need to have new prescriptions every month, and it can be tricky when somebody has catatonia, and if they run out, they'll relapse. So eventually, she did relapse into a depressed and catatonic state. She was readmitted, treated with antidepressant and lorazepam. After several weeks, we discussed ECT again. Again, another meeting with lots of family members, and I think this time, we built a lot of trust with the family, and so they let us go ahead and do ECT, and she had a sustained remission after 8 bifrontal ECT treatments. So, so that's all. And then one more case actually is a mania case. This is a 68-year-old divorced woman admitted to the older adult inpatient unit after being brought by police for creating a public disturbance. She'd had bipolar disorder since young adulthood. She had bipolar type 1, and she was diagnosed as being manic. She had refused pharmacotherapy. And we had a hearing, and she was approved for involuntary medication. But you may know that the usual anti-manic medications like lithium, sodium valproates are oral medications, and you can give antipsychotic medications for that. And we tried, but she had significant side effects from those, and it put her at risk for falls. So we really didn't want to treat her that way. And with encouragement from her sister, she eventually signed for ECT. Her manic symptoms fully remitted after a course of 7 bifrontal ECT treatments. She agreed then to start an oral mood stabilizing medication. She was followed up with our senior outreach service for years, working closely with her sister, who helped monitor her medication compliance. And with her compliance, she improved and enabled her many years of stability with enjoyment of church activities, family walks, and baking. So, so those are people who were very severely ill and improved with ECT. Now, ECT is efficacious, but like everything in psychiatry, it's not a cure. So there have been studies on how soon people relapse after they respond to ECT. There have been at least a couple good studies looking at 6-month depression relapse rate. So you have a course of ECT, and you see how long somebody relapses. You look out to 6 months. So if somebody is discharged after a course of ECT and they're not on any medication, they're just put on a placebo, which these days nobody would do that study, but your chance of relapse is 84% at 6 months. That's a very high relapse rate. If you're on an antidepressant, it goes down to 60%. If you're on nortriptyl, in this case, nortriptyline and lithium, or an antidepressant plus an augmenter like lithium, your relapse goes down to 39%. And a more recent study was a little more positive. It was a geriatric study or people over 60. And in that case, if you were on antidepressant medication, in this case, it was venlafaxine and lithium, so a combination of two medications, your relapse rate was only 20%. If you had maintenance ECT, your relapse rate went down to 13% at 6 months. And with maintenance ECT, people have what we call sort of booster sessions where they'll have a course and then they'll be tapered down to say, let's do a treatment once a week, once every 2 weeks, and then perhaps once a month or so, and to prevent people from relapsing. And these people had maintenance ECT plus medication. So that really brought their relapse rate down. So that's all the good news about ECT. Now, some of the bad news, every treatment has risks. So mortality rate is very low. It's less than 0.01%, so 2 to 10 per 100,000 treatments. It's quite low. It's about the same risk as just having anesthesia. The serious complication rate is also relatively low. About 1% of patients have a serious complication, and by that, it's something that needs to be addressed acutely medically, and it can include cardiac arrhythmia or problems breathing or a prolonged seizure that needs treatment. The most common would be a cardiac arrhythmia, which would be a abnormal heartbeat, which can typically be treated, but it's considered a serious complication. The common adverse effects are headache, nausea, muscle aches and pains, transient cardiovascular stress, and cognitive impairment. In terms of the cardiovascular stress, there can be transient increases or decreases in blood pressure and heart rate. Heart rate can briefly decrease or stop with a stimulus. Heart rate and blood pressure typically increase with a seizure. Rarely it can lead to problems with cardiac blood flow or oxygen, but these kinds of complications can be prevented if patients are treated with certain medications. Cognitive impairment is the one thing, though, that we don't have a medication to treat. And so we're still working on trying to improve. If you break the cognitive impairment down, it kind of comes down to what we call an acute confusional state after the treatment. So people wake up, they've had a seizure, so they're confused. That usually lasts 15 to 30 minutes. It can be prolonged in some patients. Typically, people are calm or mildly restless, but on occasion, people can get agitated and require medication to calm them down. That's fairly rare, but it happens. Then there's something we call anterograde amnesia. That's the memory problem where you have a problem forming new memories. And that happens around the time of the treatment, so that your memory is not so good for events that happen around the time of the treatment, like recall of a hospitalization, for instance, that typically will resolve in several weeks after the treatment. As I said before, though, because of this, we do ask people to limit making important decisions and doing anything dangerous. And then there's retrograde amnesia, which is losing memories happening before ECT. Now, this typically are memories during or close to the time of the course. Rarely it can involve memories months or years prior. It's greater for public events than for personal information. And the impairment can last for several months after the course. This is not profound memory loss, so you don't forget who you are, or you don't forget the names of your family members, but it can affect your functioning, and it is bothersome. So therefore, ECT has sort of an acceptability problem because people are aware of these issues, and people's attitudes vary toward ECT quite a bit, I think. There are a lot of misconceptions and negative attitudes in the general public, even among medical students and health professionals. And worldwide, many people really don't consider ECT a safe and effective treatment. And it really depends on how you get your information. So, if you get people in terms of, there have been studies looking at how people get their information about ECT, and the top sources are, no surprise, a friend, films and television, a doctor, newspapers and magazines. And individuals who get their information from a doctor have usually fewer misbeliefs and less fright about ECT. And of course, if you get your information from films and a television or possibly a friend, you're more likely to be afraid of ECT. Um, Good news is that for people who have ECT, typically their attitude toward ECT improve after they get ECT. Now, not necessarily always the case, but that's generally the case. Most people with a course of ECT are usually underwhelmed with the frightening aspects of it. It's not they're unconscious during the treatment, so it is not it's the experience itself is sort of a non-experience. There are side effects, but getting the treatment is more worrying about the first one is the most, I'd say, difficult part. So ECT is unacceptable to many people because a reasonable concern over adverse cognitive effects that I've mentioned already. It is a concern, and it does disturb people, the idea of having this. Nobody likes to have their cognition interrupted, even though it does typically normalize after treatment. The other reason it's unacceptable is that there is a certain amount of fear that's fueled by misinformation, including dramatic distortions of ECT by the media and some groups that actually oppose ECT, like the Scientologists. So, as a result, ECT tends to be underused. So, there was a study done to look at the percentage of people who have in the U.S. who have major depressive disorders or major depressive disorder or bipolar diagnosis. And they looked at 969,277 privately insured patients. So, pushing a million. And they found that the rate of ECT use was 0.25% on average. Not 25%, but 0.25%. And as you can see here, it kind of broke down interestingly according to region of the United States. So the Northeast had the highest at 0.28%, middle in the middle, and then the West had the lowest at 0.19%. So the conclusion that these investigators drew was that the use of ECT is exceptionally uncommon and limited to patients with extensive multimorbidity and high levels of service use. So really, most of the time, it's reserved for the sickest of the sick, and probably it is underused. So I'm going to switch tracks to TMS. And one of the reasons why TMS is important is because a lot of people aren't willing to have ECT, and it's another less invasive option, and it can work for people, and so it's certainly a good it's certainly a good option to have around. At the end, I'll sort of compare the two, but why don't I dive into TMS here briefly? It's a non-invasive procedure that uses very brief, less than 1 millisecond pulsed, strong magnetic fields to induce an electric current in a localized region of the cerebral cortex. So we use an electromagnetic coil that we place on the scalp and induces a focal current in the brain that is large enough to set off action potentials to get neurons to fire. And this temporarily modulates cortical function. So you see here, this is what we call many of you are probably familiar with this. This is a sort of butterfly or figure eight TMS coil. Right now it's placed over somebody's motor cortex. And when we do that, we stimulate to cause a twitch in somebody's finger to find out what we call their motor threshold. And then we can individualize the dose of the TMS according to their motor threshold, just like we individualize the dose of ECT according to somebody's seizure threshold. So what we're trying to do is give everybody the right dose, not too much, not too little. The area that is used as the target for the treatment in major depression is typically the left dorsolateral prefrontal cortex, which is around right here on the left side of the skull. That's where we would put the coil for retreating. This is where we put the coil when we're trying to evoke a twitch, so we can find out how excitable somebody's brain is and how much to dose. So TMS does not, unlike ECT, it does not require anesthesia. We are not trying to induce seizures. Seizures are a very rare um, adverse effect of TMS. We almost never see them. Um, it it does not cause cognitive impairment also. So there are many advantages to TMS. Um, TMS has been cleared now, not since 1938 like ECT, but since 2008. So 70 years later, TMS was cleared by the FDA, and it is cleared for severe and treatment-resistant major depressive disorder. So unfortunately, it is not cleared yet for bipolar disorder. It was cleared also for um, OCD. It's cleared from some non-psychiatric indications like migraine. Um, and there are different types of the TMS, and I'll go into it. But 10 years after the original clearance, there was another kind of TMS that came along, and I'll talk about that intermittent theta burst that was cleared 10 years later in 2018. It was indicated for smoking cessation, also what we call anxious depression. And then in 2021, there was another form, what we call accelerated intermittent theta burst, or the SAINT protocol, the Stanford Accelerated Intelligent Neuromodulation Therapy protocol. That was cleared more recently in 2021. But again, the issue here for this group is that it is not cleared for bipolar disorder, unfortunately. TMS coils vary. This is the one we saw earlier, this butterfly or figure eight coil. There are also these what we call H coils. And these coils, they're in a helmet you put on the head, as shown here by Dr. Oscar Morales. And they are enabled to penetrate a little deeper into the cortex in terms of the current that they cause. They also stimulate more of the brain. It's more diffuse stimulation. So here's the figure of eight coil, and here's the H1 or helmet type coil. So in terms of the approvals by the FDA approves a device with a certain kind of protocol. So you're probably familiar. So the original protocol is the one you're probably familiar with. And that's the one that takes 6 weeks. You have 30 sessions over 6 weeks. And we stimulate at a frequency of 10 hertz right here over the dorsolateral prefrontal cortex. And we dose this at 120% of somebody's motor threshold. So if we can elicit a twitch in the person's finger at their motor threshold, then we increase the dose by 20%. And that is our dose that we then target right here, this area of the brain. And people receive 4 seconds of stimulation, followed by 26 seconds of no stimulation. That happens repeatedly 75 times over about 38 minutes for a total of 3,000 pulses per session. And over the entire 6 weeks, people get a total of 90,000 pulses. That's the original protocol. And then that was, and what I can say about that is that unfortunately, the response and remission rates, although they were adequate for approval, they're nowhere near the rates of ECT. So the response rate was 24%, the remission rate was 14%. So that's like about 1/3 of what ECT is, unfortunately, but enough to get approved. And then other studies have shown that other studies have sort of confirmed this relatively low rate. Another study, a meta-analysis, showed about a 29% response rate, 19% remission rate with that protocol. Then there was approval of a slightly modified protocol, pretty much the same thing, but it was compressed more during the session so that the session time was now half. So instead of 38 minutes, it was like 18 or so minutes. Still 90,000 pulses over 6 weeks, but the sessions took half as long. That was called the DASH protocol because it's a bit faster in terms of the sessions, but not the overall 6-week course. And then came along in 2018 this intermittent theta burst, which was a different approach. Again, it's still dosed at 120% of somebody's motor threshold, but now we give it these pulses at a higher frequency. Instead of 10 hertz, it's 50 hertz. So we wind up giving a more intense train of pulses, and the sessions are now only around 3 minutes instead of 18 minutes or 38 minutes. And still 30 sessions over 6 weeks, but now the number of pulses are 18,000 pulses, so much less. So you'd think, is it as effective? Well, the FDA was interested in that, and there was what we call non-inferiority trial done where the original RTMS protocol was compared to this intermittent theta burst protocol, and the intermittent theta burst was found to be what we call non-inferior. So in this study, the response rates were actually 47% and 49%, and remission was around 32%. What's interesting here is it's not a sham-controlled trial. In other words, they were comparing one form of TMS to another form of TMS. And when you do that and you don't have by sham control, I mean it's like placebo controlled, but in a device study, you use the term sham control. And when a sham controlled study, there's very little placebo effect. And so the response and remission rates are typically lower than what you see in this kind of study, where people know they're getting treatment. Nobody's getting sham. And so there is some expectation of improvement, and that tends to push up the response and remission rates. And so that pretty much explains why these higher rates. But regardless of that, the intermittent theta burst approach seemed to be as effective as the traditional RTMS approach and was approved. So a lot of groups do this now because the sessions are, 1/10 the time of the original. But still, the efficacy is not as good as ECT, and people wanted to bump it up more. So the idea of better targeting came to the fore, and people wanted to try to use functional MRI to visualize the depression-related brain circuit activity and focus in on that circuit in every given individual. So to very much personalize the treatment to an individual's brain and their depression circuit. Neuronavigation systems were developed to target the dorsolateral prefrontal cortex region that was most involved in the depression circuit. So again, we're looking at the left dorsolateral prefrontal cortex, but now using functional MRI, we're trying to find that precise point in somebody's dorsolateral prefrontal cortex where we think we're going to get the best benefit, choosing that as the target. So in 2022, the FDA cleared this accelerated protocol using intermittent theta burst. It's called SAINT. It's the acronym for Stanford Accelerated Intelligent Neuromodulation Therapy. So it's just like this intermittent theta burst that I talked about earlier, but the whole course is accelerated. Instead of a 6-week course, we're now talking about 5 days, right? So instead of 6 weeks of 5 days each, it's 50 sessions over 5 days. So with that, you get a session 10 times a day for each day. And you wind up getting a total of 90,000 pulses, which was, if you remember, the same number of pulses in the original 6-week course for RTMS. You get that over 1 week. Now, and this has recently been kind of, I guess, brought to market by a company called Magnus Medical. And like other forms of TMS, it is only approved for major depressive disorder. This is the trial that got the FDA approval, and the results are much more impressive than other TMS trials. As you can see here, they compared it to sham, so placebo, and the people who got sham, you can see this is their depression scale score. It did not change much, came down a little bit, but not much. The people who got this Saint protocol, it came down quite a bit, and it went back up a little bit, but still a much improvement. So the response rate here was about 71% with a remission rate of 57%. And then they looked at 4 weeks later, and it was pretty similar. Not quite as good, but pretty similar. So here we're getting response and remission rates pretty close to ECT. And so that was pretty impressive. This just shows you where the two groups ended up. The folks who got the real treatment wound up with a much lower depression scale score. There is some good news for bipolar disorder. People are actively working toward trying to get this form of TMS approved for bipolar. There's one sham-controlled trial of this in bipolar disorder, 24 participants, the same kind of protocol as Saint, and they did a sham-controlled trial. And you can see here, these are the people who got sham. They had no remissions at the end of treatment, and the people who got the Saint protocol, they had 50% remission. So that's pretty good. So that is good news. It does suggest that there's some possibility approved for bipolar disorder. So I'm going to sum up real quickly. You may be asking yourself, well, when would I get ECT versus TMS? And in all situations, people have tried medication and psychotherapy, and they've been found to be insufficient despite everybody's best efforts. And in this situation, TMS is usually preferred over ECT as the next step because it is less invasive and it does not adversely affect cognition. So most people would choose to have TMS over ECT. However, I would recommend people considering moving straight to ECT if for the following reasons. So if the conditions are such that the severity of somebody's symptoms are so bad that it's medically destabilizing. For instance, they're not eating and drinking or moving, and they're at risk for bed sores. Their electrolytes are affected because they're not drinking, and they're seriously in danger of dying or being irretrievably ill medically. Then you don't really ECT is a better choice in that situation because it tends to act quicker. Also, depression with psychotic features. Most commonly, it's delusions. People will have delusions like that man I referred to before, where he thought he did something horrible financially. The studies that have compared ECT to TMS, at least in the past, have shown that people with severe psychotic depression usually do not respond that well to TMS. So in those cases, I typically suggest going straight to ECT. Also, if you have catatonic features, I would suggest going straight to ECT. If there's an imminent suicide risk or any other reason for a very rapid response, again, I suggest ECT. The other reason to consider ECT is that it is cleared for bipolar depression, and also for mania and mixed states, and so it's much more likely to be covered by your insurance. There is no convincing evidence so far that TMS will help with manic or mixed states. So if you have bipolar disorder, at this point, it's pretty expensive to get ECT for depression, and in the other conditions such as mania and mixed states, there's no real evidence that it works. So those would be the conditions where I would consider having ECT before I would have TMS. Otherwise, it may be reasonable to have TMS first, again, because it's a more benign procedure. So that's my talk, and I'm happy to entertain questions. Should I stop sharing, maybe? Okay.
I guess. Thank you. Let me mention what's in the chat and then
Okay.
throw it open to others. Where am I? There was one question I think you dealt with. It was asked, is ECT given under general anesthesia because otherwise it would be too painful?
It would be frightening. Yeah. It would be frightening. It could also be painful, but the main thing is the issue of being paralyzed and awake is very frightening.
Okay. Um, there was a comment from a 76-year-old female at 13 ECT treatments at Shepherd Pratt.
Uh-huh.
They sent questionnaires, but I did not receive a follow-up after each procedure and felt short and long-term memory had been compromised, and that information has been relayed to the ECT unit.
Hmm.
So that
Um,
is a comment about a past procedure that's hopefully
yeah,
common today.
and certainly, and I should have mentioned perhaps that as no surprise, as you get older, you are more vulnerable to cognitive impairment from ECT. Um,
Uh,
And it really is, it's a matter of the risks and benefits like any procedure. So if you know that ECT is the only thing that's going to get you out of your depression, then typically people will decide it's worth it, even though they have to put up with some cognitive impairment,
okay.
knowing that if they persist in their depression, they could wind up dead. So.
Okay. And by the way, if the person who did this wants to say anything else, you can feel free to do so.
Um,
Uh, sorry.
did that person have a question for me about that or?
No, I think I was more a comment, a description than a question.
Okay.
Or
Okay.
I can, and she can chime in if she wants. Um, Another is a more technical comment, and again, not a question about
Uh-huh.
the video issue. Uh,
Okay.
if you built this presentation on another platform like Google Slides and downloaded it to PowerPoint, none of
Okay.
the videos would be embedded. They would download as pictures. The videos would have to be imported again. That is why the video isn't working. So this is a
Okay.
technical comment about getting videos to work, which
Okay. Thank
um,
you.
if there's a real desire, we can arrange to put people in contact. But I'm no expert on this. Okay,
Thank
that's
you.
all.
Yeah,
That's
I
that's
appreciate that.
that's all I have. Let's throw it open. And oh, and I see a couple of hands in the air. Um, yeah, I see two anyway. Elaine.
Yes, I'm the 76-year-old female.
Okay.
Ah,
With the,
Hi, nice to meet you.
nice meeting you too. Um, I made the comments. This was my third bout with depression, and
Hmm.
my first bout was 2011. That was the first time I had depression, and this this latest one, I actually had to ask them, am I having a bilateral or, I had to ask the questions. They weren't really forthcoming. They just, they went through I received a questionnaire um, beforehand and then n never any follow up. So
Hmm.
I was wondering about that.
Yeah, well, I mean, it's always a good idea to, have a conversation with the patient so they understand what's going on. And um, yeah, I don't know. I mean, I've never worked at Shepherd Pratt. I mean, and I know they do a lot of ECT. I I don't know what to say. I guess uh you didn't ask them questions, but they didn't volunteer the information. Is that it?
In fact, um, I had, I was recently in Shepherd Pratt for um, 6 weeks,
Uh-huh.
and I had 11 of the treatments, and then I had two, post discharge. So I've had 13 within
Right.
in the last 2 months. And I
Right.
actually recently I sent them. I sent them an email telling them that, I don't right now I don't want any maintenance because it's compromising my
Uh-huh.
memory, and
Right.
I want to be the one to decide when I have the maintenance. Even and
Uh-huh.
they say, well, who does she think she is? But
Hmm.
when I and I asked the question, and I actually had I CC'd my son, my sister, my therapist, my
Hmm.
psychiatrist, so they could see who my support system was.
Right.
And so I actually called them 2 weeks after I sent the email to see if they had received it because I couldn't send an email directly to the doctors who perform it. So I had to send it to
Hmm.
this. So
Hmm.
after I did that, I called them and followed up and I told them, they said, well, are you calling to make an appointment? I said, no. I said, I was calling to let you know that I want to meet one to decide. And they said, oh, no problem. So,
Hmm.
so that,
Yeah, well,
that
it is always up to you. I mean, they can make recommendations like, well, this is what we're recommending for maintenance, but certainly it's up to you to say whether that's something you want to do or not.
right. But, I just wanted I just didn't want to have to go through the long process of, I had to go through the long process of having my psychiatrist give me a write up and, all that.
Right.
So,
Yeah.
uh,
Yeah.
right now, I'm doing okay, but it was kind of scary to me because I think it's my short and long-term memory because I had a very good friend whose husband died a year ago, and
Hmm.
I had no recollection of actually being at the funeral when I was there. A lot of things like
Hmm.
that happened.
Right.
So
Yeah.
that's kind of
Yep.
that's kind of scary.
It is. It is. It's disturbing.
Right,
Um, and in terms of whether to have the maintenance or not, it's obviously it's your decision and it's a trade-off. I mean,
right,
there's evidence that maintenance prevents relapse, but on the other hand, right now it sounds like you've got significant problems with your memory and you'd like to hold off for a while,
right,
and see how that goes and do your best with medication for the time being. And that's a reasonable choice. I mean, like the person I mentioned, the first person I mentioned wound up having like 3 courses of ECT over the course of his I don't know how many years it was now, but he chose not to have maintenance and he did
right,
relapse, but then usually you catch them before they get really bad. So yeah,
right,
either approach, it depends on the individual, what's going
right,
to work best for you.
right. That's
Okay.
responding to my inquiry.
Oh, you're welcome.
Sorry. Oh, okay. Maybe it's relevant to say as usual that you know these sessions are intended to provide information, but they're not a substitute for a specific advice from your doctor. And
Right.
another comment, a question from Patricia.
Hi, doctor.
Hi,
I
nice to
I
meet you.
thank you. Nice to meet you too. I have a I also had ECT at Shepherd Pratt maybe about
Uh-huh.
15 years ago,
Okay.
for several weeks. Um, and I didn't. I'm a bipolar person. I
Hmm.
didn't receive any benefit
Mm.
from it at that time. So. But still I'm considering doing it again
Hmm.
since I think my symptoms uh I I'm having I'm thinking I'm in what do you call it, psychomotor decline or something. I
The
have a
psychomotor
difficult,
retardation. Yeah,
yeah,
that you're kind of slowed down. Yeah.
yeah, really slowed
Yeah.
down in
Yeah.
thinking and movement as
Yeah.
well. um So that kind of interested me that
Right.
maybe it was a good idea to try it again.
It could be. And have you talked to your primary doctor and made sure that there's no medical issues that are slowing you down, like thyroid issues or anything like that?
Yeah,
Okay.
it's not that. I
Okay,
mean,
good.
it's just that I'm in a very, very down depressive state, and
Mhm.
I think it's the depression that's doing this to me. Um,
Right.
I I was interested in catatonia too. I mean, sometimes I feel like maybe I'm partly catatonic.
Hmm.
Um,
Hmm.
but
Yeah. Well, yeah, there's a spectrum all the way from, what we call, psychomotor retardation to catatonia. And
mhm,
catatonia is sort of the extreme form of it.
right. Okay.
Yeah.
Um, all right. So I guess my question is, I see that my circumstances might have changed somewhat
Hmm.
and that it might be more beneficial than before, but seeing that I tried it 15 years ago with no success, I guess my first question is, have the efficacy rates of ETC improved over the last 15 years?
No, I can't say they have. I don't think the efficacy rates have improved. Um, no. But it could be, did you have these similar symptoms back then that you're having now, or is this different?
That's a long time ago. I don't
Yeah.
remember.
Yeah.
That's a good question, though. It's a
Yeah.
good question.
Yeah. I mean, it's always tricky predicting success with ECT.
Mm,
As I said, I kind of gave those features that predict success, and you're right, psychomotor retardation is one of them. So that suggests you might be a good responder. Um, um, and it's hard to know. I would talk with your psychiatrist, see what your psychiatrist thinks about it, and go from there. Um, See if your psychiatrist agrees that it might be a reasonable approach.
well, I think she has asked me whether I would consider doing it again.
Uh-huh,
And
uh-huh.
I said no, but I wanted to sit in on your meeting
Sure.
to get
Yeah. Well,
more
I'm glad you did.
information. Yeah,
I'm glad you did.
well, thank you. And I also wanted to mention that I had the TMS
Uh-huh.
with no success, but you're saying that TMS wasn't approved for bipolar disorder. So
Right.
I was wondering why they gave me TMS.
Well, so you can, even though it's not FDA approved, you can still give it. It's not like it's illegal or anything. It's just that it's harder to get insurance to pay for it,
I see. Okay.
typically.
Okay.
Yeah.
All right. Well,
Yeah.
thank you very much. I've enjoyed your presentation.
Oh, thank you. You're welcome.
Thank you. Are there other questions, comments? Did I miss anything in the chat?
Yes,
Anyone
there's
else?
a couple in the chat.
Oh, Stephanie, please, then why don't you rate, tell us them?
Sure. Jake asked, physiologically, what is the difference between bipolar 1, bipolar 2, or other major depression that influences the effectiveness of TMS or ECT?
Hmm.
Mm, wow. I wish I knew the answer to that. Wow. I don't have a good answer to that. We don't, I mean, I don't know. We don't know. You know, we don't know so well what causes these disorders. We're trying to find out. Bipolar disorder seems to respond, one thing seems to respond even more quickly than major depression to ECT, and we don't know why that is. Whether there's something about the brain of people with bipolar disorder, this ability to switch from one state to the next that might make them somehow more responsive to the treatment. We don't know, but uh, I wish I could answer your question intelligently, but we don't have a sense for, why people get better with these treatments. And in terms of TMS and bipolar disorder, it's clearly some people do get better with it. It's just, the game of getting things FDA approved is a game of it's a financial game, and bipolar disorder is much less common than major depression, and therefore, you unfortunately you have to have some company that's willing to invest in that. And so it may eventually happen. I mean, I don't think that there's anything about the bipolar brain that makes it inherently less apt to respond to TMS. It's just that it hasn't gotten approval yet.
Okay. And there's one more question. I think I see it, or Stephanie can say, Judy is asking, how do you decide how many ECT treatments to do?
Yeah, good question. Well, the best case scenario is somebody responds rather quickly, and it does happen, and you basically treat until the person's symptoms have gone away, that they're remitted. That's the best case scenario. And then if people's symptoms don't completely remit, then the question is, how long do you continue? And usually, I mean, it depends on somebody's tolerance for the procedure. If people tolerate the procedure quite well, they're not having a lot of cognitive impairment or other side effects. Many people will want to go out to, 6, 7, 8 treatments before they'll sort of call it and say, okay, this person's not going to respond. Um, Practice varies that way. Some people think, well, you should give people 12 treatments because they could be late responders. Practice varies. But once you get some response, then you usually continue until you get really no further improvement after like 2 consecutive treatments. And so, yeah, practice varies. And again, a lot of it depends on, the risk-benefit ratio. If you've got somebody who's been depressed a long time and they really want to get better and they're tolerating the procedure really well, you're going to probably be more apt to, give them more treatments and more opportunity to respond than somebody who is not tolerating the procedure well. Maybe they're having a medical complication or they're having significant cognitive impairment, and then the risk-benefit ratio changes, and you're probably less apt to, push it and give them more treatments to see if they're going to respond. So it comes down to each individual and how much they're improving and how much adverse effects they're having. Does that make sense?
I think so. Okay, are there other questions that I'm missing? Stephanie, have I missed anything? Do you want to say anything more about plans for this presentation being up on the website in time?
Sure. Judy says thank you for your response. And in terms of the video, we should have it up in the next couple of weeks. And that will have closed captions. Hopefully all the typos that AI makes on the medications will be fixed. And I think that's it.
Okay. Kristen, thanks you for a very interesting talk. Anything else anyone wants to say?
Well, I'll just thank everybody
Go
for
ahead.
being such a great audience
Well, thank
with
you,
interesting
Doctor.
questions. Well, you're
Thank you.
welcome.
Thank you,
You're welcome.
Dr. Bill. We appreciate it. Again, this talk with all its details and slides will be up, and many people may want to come back and see it. And maybe we'll have occasion in time that there can be an update on progress being made with TMS.
Okay. Yeah. Sounds
Okay.
good.
If there are no other comments, then we'll call it a night. Thank you,
Okay.
Doctor. Thank you all for attending. Check
Thank
out
you.
our upcoming programs.
Bye-bye.